Good evening and welcome to the grand finale of season 34 of Doctors on Call. As they say, it's not easy getting old. Sometimes it's especially hard taking care of someone you love who is dealing with geriatric medical issues. So how do you make the big decisions? When do you discuss no longer driving or nursing home care? I'm your host, Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School in Duluth. And tonight we're talking about geriatric care. We're ready to take your questions locally at 218-788-2844 or toll free at 877-307-3762. Our medical panelists this evening are Dr. Mark Boyce, a geriatric care specialist with Essentia Health, Geriatric and Elder Care in Duluth, Dr. Amy Greminger, a geriatric care specialist with Essentia Health and Geriatric Elder Care in Duluth, and Dr. Addie Licari, a family physician with St. Luke's P.S. Rudie Medical Clinic in Duluth. Our medical students answering the phones tonight are all from Minnesota: Lindsay Collier from Plymouth, Minnesota, Sam Klinker from Little Falls, Minnesota, and Corey Limburner from Hinckley, Minnesota. And now on to tonight's program. But before doing this, I want to take just a special moment and look back and think about one of the great geriatricians that I knew and who was so important in making this show work, Dr. Ben Owens, who passed away a couple of 3 years ago. And at the same time, because I won't get time at the end, thank my other hosts, Dr. Ruth Wester and Dr. Alan Johns, and Dr. Linda Liskowitz for all the work that they've done to make this program continue to be fresh and enjoyed by all of you. So at this time, I'd like to again introduce our panel. Dr. Boyce, you work for Essentia. Do you want to tell us a little bit about your specialty and what you do?
Thanks, Ray. Mark Boyce. I'm a family physician, and for many years I did full scope family medicine. And I found that a lot of my medicine, even back in the early practice, included a good percentage of elders. And so caring for the older adult has become a specialty unto itself, and I thought that that was a good part of medicine to focus on. It still has a lot of the issues of family care and communication with family, but it's been a very fun area to focus on. Most of my care now is in facilities, both long-term care, typical nursing homes, assisted living, which is sort of a in-between assist in living, but not a full nursing home. And then what's really a very big part of medicine today is transitional care. So if I've had a stroke, or if an older adult has had a stroke, they need a recovery time. Perhaps they're not well enough because of heart or lung disease. We call those comorbidities. They need to be in some sort of transitional care. And that's where a lot of our focus is and a lot of our healthcare expenditure. And so it's a good place to be practicing.
Thank you. Dr. Greminger, a little bit about yourself.
I'm trained as an internist, so I've always worked with adults primarily. And then later, I initially started out working in the hospital, and that wasn't my cup of tea, but I really enjoy working with geriatric patients in the community. I work primarily in the nursing home. I've also done work with hospice care and palliative care, and that's a real passion of mine. I think one thing that's really special about people at that stage in their life is a lot of times they are transitioning toward the end of their life, and to help them define their goals and their wishes and to really kind of tailor the care that they need to what the kind of care that they want is a beautiful aspect of geriatric medicine and something that I'm really passionate about. I love it.
Wonderful. Dr. Licari, you're a frontline family doc.
I am. I have a special interest in geriatrics that probably dates back to my school breaks, which is this week for most people in this area, where I spent most of my time at my mom's nursing home, where she was a physical therapist assistant. So I have a special place for sort of geriatric patients, and eventually I hope to sort of transition my practice into that. I do see a fair amount of patients in my clinic who are in the geriatric age, and I also visit nursing homes as a family doctor.
Thank you. Nice review of what you guys do. Dr. Licari, start with you. This person is wondering, when parents need to stop driving, how does one convince a mom, a dad, a relative to give up their car? And in the old days, out there in the sticks, we used to tell them to go take the coil wire and throw it away. But I don't think that works so well anymore.
Doesn't work so well, but I've actually had patients tell me that at times, that they've taken a couple spark plugs out or something. It usually, if there's an unwillingness to quit driving, it does take a fair amount of effort, both from multiple family members and from even seeking the help of your primary doctor to have a discussion about the safety of driving and reasons why it is probably not appropriate to continue to drive. A lot of patients sort of think of driving as their one last thing they've held on to. I mean,
it's a right.
It's a right, and it is something that, you know, is a necessity almost in an area like this where they have to get to the store, you have appointments to go to, and it's a sense of freedom in doing that. So it's a really hard thing for people to give up. I have had discussions with patients and with families, and a lot of times if you do bring up some of the things that they're not necessarily thinking about, like, can they see? Can they hear enough to hear not only sirens and other vehicles, but could they hear something on the street or someone yelling to them? And I found that if you have a really open discussion, there are a certain, you know, amount of people who will say, yeah, I don't think I should drive. There are a group of people who want to drive kind of to the end. And a lot of the times if you meet with your doctor and you have this concern, I'll have the discussion that both the Driver and Vehicle Services of the state of Minnesota does some driving assessments and puts limits on the amount of driving that someone can do away from their home. Or we also have both hospitals in town have a driving assessment program that they might consider. If they can go through it and it can pass, we might feel more comfortable about them driving. But a lot of patients will say, you know, if I have to do that, I guess I'm not up to it.
It reminds me, one night I got a call from my dad. She won't let me drive, and she's on the other line, and she says, he tried to kill us. So that took care of that one. Yeah. Any other comments on the driving evaluations? You guys are involved with that?
A lot of times it's a what if. What if there's an accident? And so if you play a little bit of the what if game, it's sometimes quite helpful. And also I found that having the most vocal opponent to the losing the driver's license, it's usually the eldest son, at least in my family it was, having them drive with them. They oftentimes will take a step back because the driving is generally horrible. My mom's was horrible, and I think that helped. It's not the only thing. So sometimes doing a personal driving test, and that could be complemented by the occupational therapy tests at the hospital.
In my experience with my family, certain family members were very reticent based on family conversations. It really took somebody who wasn't a member of the family to have that conversation with them. Sometimes, you know, with parents and children, there are all sorts of role reversal and lots of things that go in with that. And so sometimes it is helpful to bring it up with an outside person like a physician or a PA or somebody who's not so deeply involved, because I think sometimes that helps to preserve the relationships.
And then another problem, sometimes when you report them as a physician, you end up getting fired too at the same time.
Correct.
So that does happen. Mm-hmm. Why don't you talk a little bit about visual problems in the elderly? Amy, you're rolling right now. Go ahead.
Oh, you know, I think I'm always amazed by my patients about when I see them, they're so lovely and wonderful to talk to, and sometimes it's easy to forget about the very real physical limitations that they have. Macular degeneration, very common in the elderly, and a lot of times that distorts the finer aspects of vision that they have. They can see general big shapes and stuff, but the fine things like reading or handwork or those things can become more difficult. I think we're really fortunate to live in a time where there is a lot more adaptive equipment. There's, you know, better lighting, there's magnifiers, there's more adaptive equipment through audiobooks and a lot of those kinds of things. I have a family member who does have some issues with macular degeneration, and it's really amazing all the resources that are out there. So when patients do have that, it's always nice to be aware of what kind of resources are out there, because losing vision happens, unfortunately, and sometimes there's not a lot that can be done to fix it, but there's a lot that can be done so people can live better with it.
And I think we forget a lot of the times that it impacts your day-to-day life a lot. And especially I've found with the vision and medications, and being able to take medications properly, being able to see instructions, even our handouts in the clinic that we hand people every time they come in that give you a list of instructions of things to do. If you cannot see, you are less likely to sort of maintain your compliance or follow your doctor's instructions.
A special area of visual loss is concerning. I knew that my dad's macular degeneration was changing when he, a Marine marksman, missed a deer during deer hunting. And I just didn't realize it at the time. But in retrospect, it became apparent that his vision loss was suddenly changed. So anytime there's sudden vision loss in an older adult, we need to think of course, migraine is pretty common, but stroke or a change in macular degeneration. So those are things that really need to be brought to the attention of the medical team.
And the cataracts and all of the things other things that can get involved. So let's move over to hearing. Addie, the questions have to do with hearing in crowded rooms, hearing aids. Hearing aids are expensive. A little insight from you guys.
And I would say that, it's a very common complaint, even above patients above the age of 45, to start sort of having some of the background noise interfere with their ability to have conversations. Oftentimes it's the higher frequency noises that sort of go out first. It's a common thing, and it influences life a lot. The problem is that our medical coverage of hearing devices and hearing aids is poor. Kind of across the board, and hearing aids can cost someone upwards of $3,000 to $4,000 for a pair. And then you have to figure out how to use them.
Well, you can double that in cost, can't you?
I
think
believe
some of the
so.
new ones are $7,000, $8,000.
Yeah.
And I don't know the regulations, but Medicare does not cover any of the hearing aids or any of those type of things. So you're responsible for that cost yourselves.
One of the better coverages is from the VA if there is hearing disability that was related to military service.
And I think most companies allow you a month to try them out, maybe before you make the final purchase. I'm not sure.
It's really good to try them earlier than later in the course of hearing loss, because there's a lot of learning that goes with hearing or relearning. I think Laura Erickson from KUMD talks about hearing aids now helping her with bird identification. And so she was markedly, according to her conversations on KUMD, markedly impressed by the hearing aids. So don't say it isn't worth it. It may indeed be worth it.
Took my mother 2 tries before she finally realized, yes, they do help. And some of these nice, small inner ear ones, a lot of my patients really like those, so it's something to try. And I guess I would encourage it, because you get a chance to listen and hear and all the other things better.
Also, protect hearing for those who have intact hearing. Snowblowers, loud noises, lawnmowers, please wear hearing protection.
At a young age.
Yeah.
How do you get an at-risk adult into assisted living? Can a doc get a court order? How does that process work? You guys do more of this, so
Yeah.
I'm looking at you, Mark.
Yeah. An older adult who is a risk to themselves can be committed. So that, yes, that can happen. You can go through a commitment process. The most common place where we run into that is in maybe not just an early dementia, but a moderate dementia, where a score on our test, if the test score is, say, normal is 30, the test score might be 18. So they do pretty well. They might even have good conversation, but they're very paranoid and really resistive to change. They don't adapt well to change either. And so that older adult might need lots of encouragement to get into a facility. One of the things is making sure that that transition, if it happens as a court order, it can, that is accompanied by as much family support as possible. And visits earlier in the day are better because the older adult tends to have their best time of day in the morning. So that's the best time of day, I think, to discuss things in the first place and then to visit once you've had that very, very difficult conversation or difficult event with commitment. Once again, if you transition to a safe place when you're adaptable, that means selling your house earlier and getting into an apartment that's accessible, that makes a whole lot more sense to me than not. It means you'll get more out of your house and get more out of your apartment, both. But that's a difficult thing. I can say that as a whippersnapper and not be realistic when it comes to my own aging too. So.
Well, I could see myself not listening to you, so that I can understand that.
Yeah.
Addie, you're on the front line. You deal with this a lot.
And I think the common thing I see and where we look to kind of intervene, like Mark talked about, is that all of a sudden you come to a crisis point later on down the road and you haven't really thought about these things and you haven't made plans for financial issues or transition of some of those financial issues that make a big difference in payments for assisted living, nursing home. And to be honest, it's really tight in this area across Minnesota, across the United States for assisted living facilities, for nursing home beds. And so when people come in crisis, they commonly will end up in the hospital with something minor, like a UTI or acute confusion. And we have a hard time sort of keeping them in the hospital and trying to figure out where we can safely kind of transition them to an assisted living, which is, it's not very doable in this climate right now to discharge someone from a hospital right to assisted living. We typically would use a nursing home or an acute transitional facility as sort of a step in that.
I would say a large percentage of the patients that we do see in subacute care are in that kind of situation where they had an acute event, they were in the hospital, and had a fall or had something happen, and they're in a nursing home and working on what we call disposition. So the social workers are working with them and their families to try to find a better place to go. Sometimes even in that setting, we do have people in the nursing homes that still insist on leaving. And in that circumstance, what we do when they leave against medical advice, and we believe that home is not a safe place for them, we report them to the state as a vulnerable adult. And then the state does some follow-up work with the patient. But that's always something that we try to avoid if possible.
But it's mandatory that you do it.
It is, and it's not, I don't trust this person or whatever. If we think that they're in a vulnerable situation, we have to report them.
Addie, we broached the word dementia.
Mm-hmm.
What does that mean?
Dementia is a term that sort of encompasses a whole bunch of different causes of memory loss, typically short-term memory loss with some more long-term retention. And so it's a general term. There are different types of dementia: Alzheimer's, Parkinson's, Lewy body, and those are all different sort of causes with their own syndromes or symptoms associated with that.
So is there a medicine for dementia?
Exercise.
Talk about it. Talk about exercise.
I think the strongest medicines for dementia are exercise and group communication. Maybe my men's group in a Bible study is helping me prevent dementia more than anything else. And so staying connected with your community, developing new interests, say learning a language or learning a different music, maybe even something outside of your normal, and then also exercising. Walk as far as you can.
Comments?
It's good advice.
What I've heard, and what seems to be the mantra about walking, is 30 minutes every day. With diabetes, of course, all diabetics should be walking 30 minutes a day. But now there's the discussion that we hear about walking and possibly growing new brain cells or better vascularizing the brain, other parts of your body, men if you're having troubles, those type of things. So there's what you say is very, very important.
Yeah. And a lot of patients ask me if I do puzzles with numbers, or if I do crossword puzzles, or if I look through the paper, will that help me with dementia? And Mark is right that socialization is so important. So when my patients ask, well, what can I do? I have them volunteer at their grandchildren's school, or meet a women's group, or do something where they're interacting with people on a regular daily basis. The more isolated we get, regardless of anything, we do develop some memory issues.
I think that there's been some other studies about brain training also, and like actual, doing therapy and stuff, and how that can enhance people's abilities to deal with certain situations. I think when we see people with problems with cognitive deficits, a lot of times it's when they're in an unfamiliar situation. When they're in their familiar situation, they can compensate actually quite well. But then when they get out of their norm, it's difficult for them. So practice on dealing with, that's why the socialization is so great, because it does allow you to practice. I think people oftentimes do ask me about medicines for dementia and cognitive impairment, and there are a couple of them out there. I'm kind of a less is more kind of person, where if I can get people by without using medicines, I prefer not to. But there are a couple of names out there on the market for Alzheimer's in particular that people might recognize. Aricept and Namenda are the two that are on the market that come to mind.
The other piece that comes up with the exercise, Mark, is the muscle mass, balance, and those type of things are very, very helpful in helping one stay younger. Because one of the questions here is, at what age do we deem elder? When is a person elderly? And has that age changed?
Well, I think the processing of aging, which there's a discussion about the loss of muscle mass, a slower mental process speed, those other sorts of things that occur with aging, I think that is occurs on an individual basis. There's a trend over time. Our biggest risk for dementia is aging, being older. Our biggest risk for heart attack or stroke is being older. So, but that's very individual. And is the trend to be older? Actually, I don't think that that's true, although the whole population's trend is to be older. We've always had old adults in the community, 100, 102. Now we have more.
I would say echo that it's very individual. I have some really young 90-year-olds that I follow in the nursing home, and I also have some very old 50-year-olds that I follow in the nursing home. It depends on people's overall health. And the young 90-year-olds are oftentimes the ones that were very active.
What about alcohol?
Certainly alcohol in excess is a risk factor for cognitive impairment, and I think probably all of us have seen that. I'm sure you have.
So,
And tobacco takes 10 years off your life.
well, that was my next question. So, don't smoke.
Don't smoke
So, what
at all.
do you mean by alcohol in excess? What's normal? I'm an old man. How much can I drink?
I think if you look up the statistics, you're at risk if it's more than one beverage a day for a woman, or two for a man, I think is considered an excess. But I think the numbers are different for different people. I think if you're consuming enough to feel it on a regular basis, that's probably not the best thing.
I want to thank our panel tonight. We've covered quite a few different topics. I think there's a lot of really good advice for taking care of yourself And I appreciate all of you talking a little bit about alcohol and smoking and exercise. And I'm with the panel. I think exercise is the most important thing we can do. At this time, I want to thank our panelists, Dr. Mark Boyce and Dr. Amy Greminger and Dr. Addie Licari, and our medical student volunteers, Lindsay Collier, Sam Klinker, and Corey Limburner. Although this is the last show of the season, remember that you can watch any of our programs online at www.wdse.org. We will be back next fall to discuss what's new in medicine, ranging from high blood pressure to heart disease to cancer and joint replacement. See you next time on Doctors on Call. Thanks for watching. Thanks for watching this season. We really appreciate you. Have a great night.